Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
I'm Dr. David Sadat. I'm a facial plastic surgeon here in Beverly Hills, California. I graduated in 2001. So it's been about, 24 years that I've been doing facial plastic surgery. My mentorship was heavily involved in fat transfer. So early on, I was really into volumizing the face in addition to surgical procedures like facelifting and neck lifting and brow lift and the whole thing that we do. And because of that, that was the beginning of the fillers, especially HA fillers and biostimulators coming into the market. And I was reached out by the companies, and it became a huge part of my practice. So I ever since I've done a lot of surgery and a lot of non-surgical because I think they are very complementary. They couple each other. And one helped me get better in surgery. The other one helped me get better in non-surgical. And then at some point, because we're facial plastic surgeons, I was reached out by different entities, especially non-surgical community, about anatomy and doing cadaver anatomy and understanding, facial anatomy for injectors. So I've been doing a lot of teaching and training on anatomy and anatomically guiding non-physicians and physicians and surgeons to do injectables.
Unfortunately, in today's world, some people, it's so easy to get these things that people have started doing this themselves at home. And maybe it's YouTube, maybe it's Instagram, who knows where they find the inspiration to do this stuff, but patients do this on their own. Have you had any experience with patients that have come to you maybe after the fact and said, hey, this is happening, can you tell me about that?
Unfortunately, a lot. Unfortunately, and as you said, it's so easy to get these. You can get them on, platforms like Amazon and Alibaba and places like that. You can order your filler. It's crazy how they have fillers on there. And also, most people think that they can watch a YouTube or Instagram or TikTok and it tells you how to do it. So it doesn't look that difficult when you can see a needle going underneath the skin and doing it. So I've had several of these. One of the worst ones was a gentleman who was a psychiatrist and was getting older and was unhappy with his cheeks getting more flat. So he ordered some filler online somewhere. I think one of the more international platforms. Filler came, he started injecting himself. And then after a couple of months, he noticed that he's got a bunch of nodules all along his mid-face and temple area. And came to me and said, I'm just here for dissolving. So I'm like, I just got to do some hyaluronidase and it should be fine. So I'm like, whoa, so what kind of filler was it? I don't know, which is a typical answer, right? I don't know. And I said, well, who injected it? Did you go back to the injector? He's like, no, I injected it myself. And I'm a psychiatrist. So I'm like, very, very interesting. So where'd you get the filler from? Online. Okay, do you know what the filler is? I have no idea. It's written in Chinese. Obviously I don't speak Chinese and we couldn't figure out what it is. And, once we had it translated, it was just some sort of a weird, probably silicone base filler that was not even medical grade silicone, non-medical grade silicone, which is very popular apparently everywhere. And I remember back before I finished my fellowship, we had a lot of those. And he injected himself. And I told him the only way is to surgically remove it, which was, very, very dangerous. Obviously, he decided not to do it and live with it. But yes, so that was one of the worst ones I've seen.
Have you had any experiences where somebody came to you in the acute phase where it's like, hey, I think I have an occlusion?
Patients do inject themselves, but I don't think it's as common as other providers injecting themselves. And you can see this on social media, on Instagram, TikTok. These are like nurses or nurse practitioners or other physicians. I mean, I'm not picking on any specialty. Basically, they say, well, it's, toxin, I can inject it, or filler, I can inject it, not a big deal. And I've had one chin vascular occlusion, and I had a STA vascular occlusion, superficial temporal artery vascular occlusion. I don't even know how one would imagine injecting their own temples because that's just a very difficult thing to do. So we had to reverse it. Thank God it was easily reversible. Some are not, but when they come in the acute phase and you get to them quickly before they get into the necrotic phase, and if you have some experience reversing them, it's easy to reverse. So we got lucky. We were able to reverse both of them. It was very stressful for the patient and for myself going through it, but I've had two of them, unfortunately.
If you're going to explain to someone, hey, this is how you treat an occlusion, like what did you do in that scenario?
Most occlusions, we're talking about skin occlusions, obviously, the ones that affect the skin, most of them have a very distinct pattern because we know the distribution of each blood vessel supply. So, for example, we know how the superficial temporal artery supplies the forehead, or the distribution of the supratrochlear artery, or the superior labial artery, or the ascending branches of the submental artery versus the inferior labial artery. So if you recognize the pattern of vascular occlusion, then you can recognize what blood vessel was occluded. And then depending on what theory you believe, but there's different theories about vascular occlusion, but I think the most acceptable theory is that the filler goes into the lumen of the more bigger blood vessel and it breaks and goes into more the smaller end arterioles and maybe capillaries, and it gets clogged there. That's why the occlusion is more of a pattern, a distribution, not just one blood vessel. So if you believe in that, then the right thing to do is to make sure that not only you get the main blood vessel and hoping that your hyaluronidase disperses to all the little branches, but also getting all the end arterioles, all of those. So I typically do try to find the main blood vessel. If I have an ultrasound in place, I use ultrasound. In both these two cases, I didn't have an ultrasound. Luckily, the superficial temporal artery was very superficial and you can see it and you can always palpate it. Majority of the time, you can palpate it. The other one was an ascending branch of the submental artery. I couldn't palpate it or see it or feel it. I would just inject in the general area of the injection, which it was so acute so that you can see the needle mark, that area trying to find the blood vessel, which is typically in the third layer. Most of these blood vessels, the big branches are associated with the muscular layer. So in the third layer, SMAS. And then I would flood the entire 5 layers of more of the distribution of the artery. And it worked. It reversed full strength with lidocaine, by the way. Because there's one more theory that sometimes these blood vessels go into spasm. And when they go into spasm, it's prolonged spasm for some odd reason. Maybe some inflammatory responses from especially the hyaluronic acid fillers. It's much less with other types of fillers like PLLA and hydroxyapatite. But for some reason, hyaluronic acids are more inflammatory, for lack of a better term. So if there's a prolonged vasoconstriction, and so if you use a little bit of lidocaine, hopefully that would vasodilate. We learned that from our, anastomotic surgeries that we do for free flap and stuff. We always injected the blood vessels with lidocaine to open up so we can do our anastomosis. So that's why I say surgery and non-surgery really couple with each other. And then and then using your capillary refill as your monitoring for improvement. Mm-hmm. Once the cap refill really returns, that's your end stage, unless you have an ultrasound that shows the flow of the blood through that artery that's affected.
Do you have sort of your own protocol that you come up with on your own based on your own experience, or did you sort of modify another template that was out there? Like, how did you know to do what you did?
I started doing these kind of things before the protocols came out. So I kind of did it just by experience, unfortunately, or fortunately, but then you add in everything you learned. So of course, all these little details that we learned in the past, amongst all the protocols, the main treatment is hyaluronidase. And unfortunately, our Hylenex in the United States is a lot less concentrated than the rest of the world. And you'll see that a lot of the protocols are from outside US where they have the 1,500 unit hyaluronidase versus us having 150 unit hyaluronidase. So that means you have to double, triple, quadruple, even 10 times more when you do these injectables. So that's one. The other modalities that we use all the time is that if you have ultrasound guidance, that helps a lot to inject your Hylenex. So those are the main 2 big ones. And then everything on the periphery that helps. Aspirin, using some sort of a Cialis, Viagra type of medications for vasodilation. Warm pack and not use ice and use warm pack to kind of help dilate again the blood vessels. Steroids, sometimes the swelling causes compression, especially with the nose, nasal tip. A lot of the vascular occlusion is compression syndrome. But then when you really think about it, when you're re-injecting the face, but with a bunch of hyaluronidase and fluid, it gets really swollen. So the steroid would help. Massaging would help. So that's in the acute phase. Obviously, as it gets delayed and you go later deeper in the progress, then you think about now that we have a necrosis or skin effect, then we have to protect it from getting infected. So antibiotics at that point and using hyperbaric oxygen and those kind of things come into play.
What would you say to patients who are maybe thinking about just trying filler on their own? It's not a big deal. I've seen other people do it. What would you say to those patients?
First of all, I just had my neurotoxin injected today, and I went to my nurse to do it because I would never ever do it because it's hard. It is really, really difficult to do a good injection. There are so many potential complications that it's not worth it. This is your health. This is a medical treatment. This is almost a surgical treatment because it's a procedure. And these procedures have a lot of side effects. When they're done perfectly, they're beautiful, they're gorgeous, they last a long time, they make you feel good, they look good. But once you have a complication, it's not fun. And complications happen. I just got a text from a friend of mine that said, somebody was injected in their neck and they're having a hard time swallowing and breathing. What do you suggest? And I'm like, okay, maybe a little bit of breathing problem. I said, typically you just wait for it to go away unless it's really bad and they have to go to the hospital. Half hour later, she texted me and said, you know what? She had to go to the ICU hospital because she couldn't breathe. So apparently they had done some sort of a neurotoxin in the neck, platysma, and they went too far, too deep because the platysma muscle, for example, is very, very, very thin to a point that a lot of us experienced injectors that have been injecting for 20 years, we can easily miss it, let alone for someone who has zero experience and injecting themselves. So they had gone too deep. The patient had to go to the ICU, stay there for a day until the breathing got better because they were having a hard time breathing. They affected I think they probably hit the vocal cord, if I'm not mistaken, or at least the muscle, one of the muscles around the larynx. So extremely dangerous. It's not worth it. This is not where you want to save money. If you want to save money on your sushi or getting an $8 coffee, make the coffee at home, you save money that way. But you're not here to save money and I think that's the main reason people are trying to do it to save money. Unfortunately, this is not one place that you want to save money. This is a place that it's your health. You want to be really safe. So I'm 100% against it. Even injecting someone with my experience injecting myself, I would never ever do it because I even don't trust myself injecting myself, let alone like a patient that has no experience injecting themselves.
Should we make it harder for people to get this filler on the online marketplaces? Like, what do we do about this?
100%. I hope. But unfortunately, this is not just fillers or neurotoxins or other injectables. I think this is across the board. People get medicines from other places. I watched a little documentary where people are getting online medicines from, like, let's say Canada or Mexico that are exactly the same as the one in US, but because we don't have FDA, it's much cheaper. And it was and I'm not picking on Africa, but it was some African little village where they were kind of making these medications and packaging them as if they're French medicine and selling to them. Because once you get stuff online, you have no idea where it's coming from. Our FDA obviously has very, very rigorous. I know a lot of people hate FDA, but I love FDA because it protects the patients. It is done for protection and safety of our population. And once something is FDA approved and under the pharmaceutical guidelines, at least we know that it's been tested, it's safe as best as possible. And, I don't know what FDA can do, but unfortunately, nowadays it's so easy to get stuff from everywhere. I wish there was a way of restricting it, but I don't know if it's possible.
What would you recommend for either a physician or surgeon? We can start with a facial plastic surgeon, right? I mean, they kind of know their anatomy at this point. What resources would you point them towards? What would you say as far as if a patient like this walks into your practice, what do you do about it?
That's a great question. And I've been struggling with this for a long time because I do a lot of trainings. And unfortunately, if you compare the field of facial plastic surgery with aesthetic medicine, field of facial plastic surgery is beautiful. We go to med school, you learn anatomy, you learn physiology, basics of medicine. Then you go to, let's say, ENT. We did otolaryngology, and through otolaryngology, we learned how to operate. 5, 6 years being in surgery, have a mentor, somebody holding your hand, how to use the knife, how to use the needle, how to use the syringe, all that. So what do you do with complications? How do you manage a patient in the ICU? This, that, that. And then we did facial plastic surgery where you were with the mentor, watching them, learning from them, talking to their patients. So it's 10, 11, 12 years of training with mentorship. Now, the laws are, and some other states are different. You are whatever you are. And if you decide to start injecting, let's say, toxins, and I'm not picking a company, Botox, Dysport, whatever, any of them, or fillers, you can just start tomorrow with no training. I think it's ridiculous. We need training. That's why we have a board of facial plastic surgery. We have an academy of facial plastic surgery. We are held to the standards. And unfortunately, because there's no board, because there's no academy, because there's no well-organized body that is in charge of teaching curriculum, testing all that stuff for aesthetic medicine injectors, we are at a disadvantage. And so until we have that, my recommendation is that, especially us facial plastic surgeons, we help each other all the time. We're kind of like, it's gentlemen and women clubs. We help each other very well. And like I have people come watch me all the time, and I'm in Beverly Hills. Most of the we have about 10, 15 of us, and all of us have people come to the OR, come to the office and watch, and just pick up the phone and call one of us, whoever wants to start, and say, hey, dude, listen, I need to learn how to do, I don't know, sculpture. I need to learn how to do radius. I need to learn how to do neurotoxins. Can I come and hang out with you for a day? And if you're someone who's really new, let's say a nurse who just graduated and young and still has the time and doesn't have a practice like the rest of us, and just find a mentor, find someone like yourself and call Peter and say, Peter, listen, you know what? I'm a nurse, I'm a PA, nurse practitioner. I want to learn this. Can I come work in your office? I work for less money, but and if you can teach me and mentor me on how to become a better injector and understanding facial anatomy, understanding neurotoxins, understanding fillers, how to deal with complications, how to deal with patients. How do you handle a patient that's not happy? And I'm sure you would love to do that. And, all of us are that. And until we have a more organized body, I think the best method is a mentor that would, take you under your wings. And then, of course, you have to supplement it with courses and lectures and conferences and other things.
What is the sort of bare minimum that if you are going to be injecting filler or taking care of filler patients, what do you absolutely must have in the office to take care of these patients?
But first of all, if you're a beginner, you must have a mentor or someone who would save your behind if you get into trouble, because it happens. So you have to have and I hate to use this term medical director because that doesn't mean anything. You need to have someone who has experience with managing complications at your, disposal, for lack of a better term. Like either you work in their office or they're right next door, that you can call, and then you have to relationship with them so you can actually call them and say, Peter, I'm sorry, I messed up. There's a little thing. Can you give me a hand? So that's number one. That's the must. And then all the other ones is there's an emergency protocol. It's published online. Again, I'm not picking on any company. The company Allergan just came up with an emergency safety and advocacy protocol, and they have it published now, where they actually document what you should have in your practice. It's for free through the reps that would give it to you if you want. And I'm so proud of them for having that, because I think it's really nice to have that. So they'll tell you exactly what you need to have to make sure that in case of emergency, you have everything available. I mean, those are the two things. And then I think everybody in the office, your staff members also need to know how to run an emergency protocol. So that's the most minimum to have in the office, plus obviously learning and all that trainings that we discussed.
You have the mic. What else would you like to add as far as the conversation on a national level about patients self-injecting fillers, or anything else you'd like to say?
I think it's our job to kind of disseminate this information and make sure that people understand this is an important message, that it's not safe. This is a medical procedure, has complications that are really devastating. Please don't do it. And I hate to put it this way. Of course, these kind of things are more for look. It's not worth it getting rid of a wrinkle or getting your lips a little bit bigger or cheeks a little bit bigger. And for that, trying to save a few bucks and have a major complications. If you can't afford it, don't do it. It's not worth it. The other thing is, it's kind of something funny, actually, I have to say. We do a lot of trainings, and during a lot of the trainings, we need models. I mean, if you're that desperate and you really can't afford getting it, call one of the trainers, call my office, call Peter's office, call one of us and say, listen, I'm willing to be a model and donate my face for training and teaching. At least get it like that for free. Have a professional inject you. Here's a solution for everybody. All the ones that want to self-inject, that's what they should be doing.
We'd like to thank the authors for their commentary and thank you for listening to our podcast. If you'd like to explore more, please feel free to check out the article in print at the Facial Plastic Surgery and Aesthetic Medicine Journal or online. We'll catch you on the next one.